Hey everyone, welcome to Compassion and Courage Conversations in Healthcare. I'm your host, Marcus Engel. This is the podcast where I teach compassionate communication, provide perspective, and inspire resilience. Today, I have the honor of interviewing Dr. Tim Cunningham. Hi, Tim. Thanks for being on the show.
Hey, Marcus, thanks for having me. Great to see you.
Great. And so like we have a whole bunch of ground that we can cover today, right, in this conversation. And I want to make sure that I get all your bona fides right. So can you tell me your position and a little bit about your academic background and professional background to date?
Yeah, happy to. I'm going to list some things. Please don't ask me exactly what I do within those roles because I'm still a little bit confused. But I'm grateful to have a bunch of seats at the table and be able to wear a bunch of hats. The primary role that I'm working in right now, I'm the co-chief well-being officer for the Woodruff Health Sciences Center. So what that means is I partner with a physician named Dr. Chad Rittenauer, and we support policy change, we support structure change, and we support individual support for the well-being of about 35,000 staff members at Emory. So that's all of Emory Healthcare. That's 11 hospitals, 250 clinics. That's our School of Nursing at Emory, our School of Medicine at Emory, our Rollins School of Public Health at Emory, and our National Primate Research Center, plus our Winship Cancer Institute. So that's the biggest hat that I wear. Another hat that I wear is that I'm the Vice President of Practice and Innovation at Emory Healthcare. So I'm the head of professional development and nurse education for our 7,000 nurses. So the amazing team that I work with, we support our nurses when they say, I want to go a different direction within nursing. We work with them to help offer that professional development and support to shift them and move them within our own institution and help them flourish and grow in leadership roles and in other roles around nursing and compassionate care. Those are the two hats I wear. I also have a joint appointment at the nursing school here, so I get to write some papers and do a little research.
And I should have introduced you as a nurse, right?
Yeah.
PhD level nurse and also a Columbia grad. So I love to hear that. And what cool work to get to do just supporting those who are taking care of patients just like me, right? What cool work you get to do. How did you get into this? Do you come from a nursing family, a medical family?
I came to this in a couple different kind of weird ways. So I did come, my dad's a dentist. He's a retired dentist. And I'm proud to say that much of my well-being work and inspiration is that we almost lost my dad to suicide when I was in high school. He was practicing at a time when, no one was talking about burnout, and he was trained in the school of, I call it the school of SUI, the school of suck it up. And he was running a practice and just like totally burnt out and took some really challenging turns in his life. Thank goodness he's still with us. Thank goodness he's gotten a lot of support. So I'm always interested and have been since in burnout and how do we care for those who are caring for us. So that's a big chunk of what drives my work. And then what also got me into nursing, which is, by the way, Marcus, the best profession on the planet. Can we agree to agree
Absolutely,
on that?
Yeah.
By far the best profession on the planet. First profession I had, I was a professional actor. I worked in different regional theaters, did some performances in the US, internationally, and I connected with an organization called Clowns Without Borders. I still sit on their board. Clowns Without Borders sends free shows to zones of crisis around the world, outside the US and within the US. We throw the idea of borders out the window. And it was doing that work, Marcus, that I witnessed some pretty extreme suffering in a rural hospital. And that inspired me to become a nurse. I went back to school, studied nursing, became an emergency trauma nurse, and I've had the opportunity to work in a bunch of level 1 trauma centers up and down the East Coast. I've worked in some humanitarian response settings. We might talk a little bit about that later. It was that work at the bedside that inspired me to go back to Columbia, study narrative medicine, study resilience and well-being, and try to figure out how do we change systems. Because the truth is, and you know this, Marcus, individual folks are doing it. Individuals are managing aspects of their own resilience and well-being. The problem is, it's not our patients. It's not people being sick as stink. We sign up because we want to work with people that are sick and injured and need care. The problem is the systems that we have in place that are preventing well-being. And so that's what brought me to the work now. And I'm ever curious to see how we can support change.
Wow. First of all, I'm glad to hear that your dad is doing well now. That's a frightening thing, right? That's a
Yeah,
frightening
yeah,
thing. And especially in the light of the pandemic, we know that suicide rates are hitting higher numbers than they have in years. Violence across our society is increasing, as we all know. Just such a time that we need to hear stories like this of survival and moving on after such things.
yeah.
So you started out. Did you have like the desire whenever you were in nursing school to be a trauma nurse? Did you have the desire to be that adrenaline junkie in the real high tense stressful situations?
Yeah, Marcus, I think a couple things brought me into emergency nursing. One was mentors and mentorship. And I think you've actually interviewed one of my mentors, Jonathan Bartels. He took me under his wing. And when I was in nursing school, and we went to different units to do different practicum hours and things like that. And John really helped me fall in love with working in the emergency department. I do love the adrenaline piece. I think what I love even more is that I'm a fixer. And in emergency departments, we can actively collaborate with teams right there on the spot. We get in the zone and we fix. A kiddo comes in. I became a pediatric emergency nurse after working with adults for a while. A kiddo comes in barely breathing, and there's nothing more amazing to be able to work with our teams within seconds and get that kid what they need to start breathing again. And that's just it's amazing. And I also, what I loved about working in emergency departments is that that's true interprofessional care. You don't have time to deal with some of the stupid hierarchies in American medical care that say, well, I'm a doctor and I'm this and I'm this, so you have to listen to me. Like, we don't have time for that in emergency departments. We just collaborate, and we bank on the shared knowledge and wisdom of everybody on the team, whether you're front desk staff, a technician, a nurse, a physician, a nurse practitioner, a PA. Like, a lot of that sometimes goes out the window when you have a really good team. And I'd argue that like that kind of team care is when the best medicine can be practiced.
Yeah, that's really an interesting point that you raised. That how much collaboration has to happen, and we have to break down those professional silos within the organization, or else, guess what? That person's life doesn't get saved. So
Yeah.
that's good stuff. So you started out in trauma and emergency care, and then went into, well, I guess you extended the education to go into leadership. But I would imagine in your time at the bedside, especially working with peds, you've had a lot of experiences. And I always, my first assignment of the year with my pre-meds is to share a time about a story about a time that someone was there for them or that they were there for somebody else. And I know that obviously working at the bedside, you've had a lot of experiences, but you also told me about an experience that you had doing some rather dangerous mission work as well, right? Global health?
Yeah. And this is, right around the time, and I think to your question about like a time when someone gave and like when I shared, and also when something was shared with me, I think about that question. And what I want to share with you is a back and forth. And Marcus, I don't know which way the caring was given with this story I'm about to share. So maybe you can help me figure this out. So late 2014, early 2015, I was actually doing my doctoral work at Columbia. I was studying global health. At the time, I was wanting to do a dissertation on the benefits of hospital clowns, physiological benefits, psychological benefits for kids and for caregivers, family members that might be caring for that child. But then, as you remember, the West Africa Ebola outbreak hit. And I had the opportunity to volunteer with an organization called Partners in Health. And I had some amazing mentors at Columbia and also amazing mentors in the narrative medicine program who, when I came back from working with Ebola patients, really helped me reground and make sense around the stories and the narratives I've experienced. So I took 9 weeks away from my doctoral work. I went to Sierra Leone, which for the audience is one of the three worst hit countries in West Africa, in the West Africa Ebola outbreak. And at one point, the Ebola treatment unit we were working in was the hottest zone in the world, meaning we had the most active Ebola patients. It was really challenging work. The survival rate for the kids that we worked with under the age of 5 was only 20%.
Oh
at
my
the time that I
goodness.
was there working with teams. So it was a lot of suffering, a lot of death, just a lot of fear, a lot of stigma, just so many things coming our way. But um, a story that continues to stick in my mind. It was the end of a long shift, and we were wearing that like head to toe PPE. One of our colleagues wore a little thermometer inside of his PPE one day just to measure how hot it got inside of the plastic suits. It measured 130 degrees.
Oh my
So like we're
goodness.
sweating balls. Can I say balls on the
Yeah.
show?
Yeah.
I just said
Sure.
it twice.
Sure.
So we're
Yeah.
sweating our balls off. We're like exhausted. We're afraid. Um, we have these face shields that are fogged the second we put them on. So being a pediatric nurse trying to start IVs on really dehydrated kids when we can't see, like it was tough work. Um, we were leaving the treatment center one day. We are going to go spray down and bleach and do like a 20-minute doffing procedure to make sure we weren't contaminating ourselves while we were spraying down with bleach and we'd been in the unit for almost 2 hours, so we were tired. And on the way out, we walked by a 25-year-old woman who was very sick. And she had gotten the energy that day to walk outside of the ward and sit on a concrete stoop just to absorb some sun. And during the whole our time there, we kind of judged how well patients were doing by if they got out of bed and went and sat in the sun during the day, and we encouraged it because it meant people were moving their bodies. We could get them to sit up and drink a little bit more, and the majority of folks that would get up and sit in the sun, even if when they were in the throes of Ebola, many of them still survived. Um, and we saw her; she was sitting out front, and she kind of waved at us while we were walking by and asked us to help her walk back to her cot. She had gotten the energy to go outside, but she was just exhausted. So three of us were walking by, and so we stopped, and two of us got under each arm, and one person sort of stood behind her and guided her hips to help her walk back to the bed. And as she started walking, we could feel in her body that she didn't have much longer on this earth. We got a sense over time. We could see a look in people's eyes. We could physically feel it. And so we walked her back to her bed, and she got progressively weaker. She was sweating profusely. She vomited. And so as we're walking, we also were trying to clean her up. We were getting fresh clothes for her, trying to keep her dignified on what ended up being the last walk she ever took. And I remember we got her to the side of the bed, and we were getting ready to set her down. We were talking her through, okay, we're going to turn you now. We're going to help you sit down. And she was nodding and with us. And right as we were about to set her down on the bed, she reached her arms forward. And at that time, I was facing her. I was the one facing her. The other two nurses were at her sides. She reached forward and pulled me into this hug and like pressed me against her body. And it was one of those hugs, Mark. You ever have a hug with someone where they wrap their arms around you and they keep their palms open so you feel their entire palms on your back? And it's like this hug that says, I am holding you with my entire body, my entire being. Like not these like broy dumb hugs that you hug another person, you're like, oh, pat on the back. But like
Right.
total opposite of that. She held me. And being held by this woman who's actively dying of Ebola, my first thought was, I'm afraid because what if she gives me Ebola? Because there was so much stigma and so much fear around it. And even debates amongst all the NGOs of like, some NGOs said early on, don't even touch your patients. Touch them enough to start that IV and get away because we're so afraid. So that fear went through my mind, and she kept holding me. And I felt her arms and her body and her hands say to me, you don't have to be afraid. It's okay. And then I remember hugging her back. At one point, I felt like it is okay. And I hugged her back, and we just held each other for a minute. And then she loosened her grip, and we laid her down in the bed, and she died a few days later.
What a what a moment that almost defies words, right? What a moment when we get to be in that special moment with someone that we know has truly been affected by our presence. That's not an experience you have every day,
No.
especially not in a situation where Ebola is present in a sub-Saharan African country. We're that's wow.
Yeah. And Marcus, people said things to us, people that weren't afraid of us when we came back home. And a lot of people were. There was a lot of stigma. But people that weren't afraid of us when we came back home said things like, "You're a hero. You did so much. You gave so much." But as I think about that moment, and I'm remembering, I feel it in my body right now,
Hmm.
remembering it,
Hmm.
what she gave to me was so incredibly generous as she was barely breathing and barely staying alive.
Mm.
So I don't know, as caregivers, are we the givers or are we the receivers? Or do we have to determine, does it have to be unidirectional? Like,
Is it best when it's unidirectional? Is that the right word? Unidirectional,
yeah, there's
multi-directional?
probably a better word. Yeah.
Yeah, yeah, but
Bidirectional is
right.
probably good, right?
Yeah, it's a two-way road. Yeah,
Yeah. Yeah.
that always seems to be the best relationship when there's not just the caregiver and the patient, but when we're actually truly human in this moment together. Gosh, what a beautiful story! Thank you for sharing that. Thank you for the how long were you in Sierra Leone?
I was working there for about 9 weeks. So I
Nine
remember
weeks.
the
Okay.
first day treating patients with Ebola with the team that I was working with was my first day was Christmas Day and last day was Valentine's Day. So it was kind of a weird American holiday bookend of doing this work.
Wow, wow! And so you come back from missionary work in pretty rough conditions to now work in leadership in healthcare and hospitals. That I love the multi-faceted approach to caring. When we look at where we are now in nursing today, and maybe even across the spectrum of healthcare, how different is it? How different is it from 3 years ago?
Hmm. It's better and it's worse in my opinion. And just to be clear, I have not done any direct patient care with people with COVID, other than working at our vaccine clinic at Emory and our testing clinic when we were super short staffed. So I've had contact, but nothing even close to the level of what the majority of our frontline nurses have seen for the last 3 years. So I'm certainly take what I say with a grain of salt. Um, Care has changed for better and for worse. It has changed for better in that so many of my friends and colleagues who have been working at the bedside, many of them have experienced strength, a sense of camaraderie, and a sense of connection with their teams that they have told me they have never imagined they could feel before. That's great. That also has come at a significant cost. A significant cost. We've lost a lot of good nurses and caregivers and environmental service team members and front desk staff and valets. We've lost many. They have lost their lives to this disease, and we should always honor them. And we've also lost a lot of people who have left the profession. I mean, I work with new grad nurses, and many have said, "I didn't sign up for this." And I'm like, where have we kind of missed that mark in reminding folks that like compassion knows no bounds, and compassion also shows up in the shittiest of situations, and we have to live that compassion. So it's strength. It's also changed the way we think about each other. And negatively, the pandemic over the last 3 years has brought a sense of profound disconnection. And I think social media has done that too. And I think a lot of these things, these ideas like we can go and connect on social media and connect through Zoom and other products, but that's not a real connection. And we're feeling that now. Why do I feel so off? Why do I feel so weird? I think we've lost that connection. So the work, Marcus, right now, no matter what hat we wear, is how do we rebuild that connection and say that it's okay and say that when the grief arises, we're going to pause for it and we're going to sit with it because it's real.
So then the question becomes, well, how do you do that, right?
Mm,
Because your position in looking over the health and wellness of your nursing staff, that's not a position that that every hospital has.
yeah.
And so what are you doing to take care of these very burnt nurses?
Yeah. From a systems perspective, there are a few things that we're trying to work on and trying because we're realizing we have a long way to go. And I'm going to say a very uncomfortable word right now. You might have to bleep me out, but I want to give you a
That's right.
forewarning. We've realized that to move forward through everything that we're going through, we as leaders need to, I'm going to say it, here it comes. We need to practice vulnerability. Ugh.
Yeah.
Because traditional leadership in healthcare, Marcus, has not been one that supports vulnerability. It's been very transactional. It's been very like, I'm in it to win it, meaning what can I do to get promoted to the next level of leadership? And we've learned that leaders that have maintained that have not made it through the pandemic. They've been managed in different directions, or fired, or let go, or they've left. So transformational leadership, leadership that is so focused on the well-being of the team, ownership of leaders taking on, my team messed up, I'm going to own that as a leader, and then I'm going to support my team so we don't mess up again. So shifting the way we do leadership, what does that look like? That's compassion training for leaders. Emory just got a grant, the pretty big grant from HRSA, and we are looking at ways to try to get more compassion training to our leaders, shifting the narrative around that, changing policies. We're working closely on, we changed a rest policy to say, hey, during your 30-minute lunch break, if you're not a salaried person, you have a 30-minute non-paid lunch break. If you need to take a power nap during that break, do it, because we care about you. We want you to be well rested. We know, Marcus, every year that many nurses die while driving home after working a night shift because they're just so tired. So changing policies like that, we change policies, bias policies. We're working on a policy right now that says if a patient comes to anybody on our team, a valet, a front desk staff, a security guard, a nurse, a technician, a physician, and says, I don't want you to come near me because you look like this, I think you believe this, I think you love these kind of people, whatever, we now have set up algorithms for the staff member to say, here, we don't tolerate that kind of behavior. And we set up support systems for our staff members to support their psychological well-being. And if that comes at a cost of telling a patient, you know what, you're going to have to wait a little bit longer because we don't tolerate that behavior here, we're going to take that risk and do it. But that's a sea change, Marcus, and that takes time in any institution. So the work we're doing is mostly structural, while at the same time trying to build networks to learn about what are people doing to take care of themselves, and how do we elevate and escalate, or elevate, I guess, the voices of the people that are doing that good well-being work with their teams. How do we build a platform for them to stand on and share that love and share that work so that compassion can flourish? And how do we as leaders get out of the way? Yeah, I think we cause more
What a
problems than
concept,
good,
right?
Yeah.
Yeah. So you gave some really great examples there of giving each worker some autonomy, even to spend that unpaid 30-minute lunch break how they want. How else are you seeing like real live examples of people, nurses that are feeling that support, that are seeing that their leadership is truly engaged with what they need to do their jobs?
Yeah. So we at Emory, we're also building out our shared governance across our system. We call it professional governance here, and there's some literature shifting the name from shared governance to professional governance. The way we see that is we see our clinical nurses showing up more and more at different leadership meetings. And that's also leaders taking that vulnerable step to invite them to the table. Coming forward, we had a nurse who came forward a few months ago, I guess it was 6 or 7 months ago now, who said, there's a safety aspect here. A lot of us have our first and last names on our badges. And this nurse came to a leadership meeting and said, we don't feel safe because people can track us down and stalk us, and it's happened. And so we've been working with our HR teams to remove that last name from our nursing name badges. That's, I think, a really clear structural change that we can make that says, hey, we realize a need for a change. We're going to work on it. But that also says we value you as an individual bedside nurse. Marcus, have you ever read Just Mercy by Brian Stevenson, or heard of this book?
I've heard the name, but I have not read the book.
So it's a wonderful book, and it's a book that I quote Brian Stevenson all the time. And he says, quote, the people closest to the problem are also those closest to the solution. And what we're trying to do is, how do we bring the people closest to the problem, which is our nurses at the bedside, to tables where their voices can be authentically heard. And so we as leaders can make decisions based on the real relevant needs of our teams, not just what we read in a paper that was published a year ago and probably submitted for the journal 3 years prior, because it takes so long to get papers out there. But that's risky, and not a lot of people are used to doing that.
You talk about the vulnerability aspect that leaders can show to their staff. leaders are hurting too.
Yeah.
All of us are hurting after the last couple of years. What about colleague to colleague or coworker to coworker? What
Yeah.
kind of how can you encourage everybody to have each other's backs a little more?
Yeah, you nailed a really critically important point right there. And I can tell you back when I was in grad school, there's a lot of literature around camaraderie. And something that we learned when the colleagues that I would, and some of these folks I worked with in the West Africa outbreak, if they called me right now, I'd say, Marcus, can we hit pause? I got to pick this call up. And if they called me and said, hey, Tim, I really need your left foot, could you mail it to me? I would get a saw and I would cut it off on this podcast, put it in an effects package and mail it to them. I trust some of these folks with all that I have and all that I know. And that came from and comes from camaraderie that we experienced while working in such a challenging setting. So camaraderie is key, and you named it in asking that question. Supporting that camaraderie. So, from a leadership standpoint, leaders are suffering, managers are suffering, our middle managers are really suffering because they're sort of serving two different groups of people. And we know that when you have camaraderie with others at similar levels, you can feel more psychological safety. So one thing that we're encouraging our teams to do and think about is, can we carve out time during the day just to be together? As we're coming back together, fewer meetings on Zoom, can we carve out time to have a little social interaction and just to chat and to shoot the breeze? Structurally and more formally, we've set up a peer support program here at Emory, and it's based on their peer support programs across the U.S. So we're not doing anything new. We are doing something that's based in the literature and what we've learned from colleagues around the country, where we have a program now where you can reach out confidentially in privacy. We've got a little QR code you can scan, and we'll connect you with another person of the same ranking. So if you're a vice president, we'll connect you with another vice president who's a peer supporter, who the peer supporters are trained just to actively listen and be present. They're not there to fix, they're not there to change. And Marcus, what's important is with our peer support program, it's not therapy. There's a lot of stigma against therapy. Peer support is simply talking with someone who already gets your professional language. So you don't have to explain that, and you can just get to the point, be heard. Evidence says roughly 75% of people that experience severe stress or secondary trauma, all they need, roughly 75% of people in this country, study was done in the US, all they need is a peer to talk with. And that doesn't solve anything, it doesn't fix anything, but it takes us a step away from that edge. And I think so many of us are getting really close to that edge, and that edge is burnout, that edge is depression, and ultimately, and most frightening for me, that edge is suicidal ideation. So we got to do everything we can.
You talked earlier about how when you were in Sierra Leone and you came back and the narrative medicine practices helped you kind of structure your experience, maybe not cognitively, maybe emotionally.
Yeah.
And so I've always, I don't say this a lot, but I really feel like if you distill down what is the whole field of narrative, it can come down to two words, and that's active listening. And the other kind of definition for active listening is compassion, right? When we are witnessing another person's suffering, we're actively we're not running away, we're not turning away from that. We're sitting with that individual. That you don't have to be trained in therapy to listen,
Right.
right? You don't have to have a MSW to listen. It just takes being in the moment and engaged in that moment.
Yeah.
And that's hard for all of us to do because we're in 21st century America right now, where we're constantly plugged in, constantly on the go. I can't even tell you how beautiful it is to hear that the system is hooking up people with someone of their same ilk and providing a listening ear.
Yeah. I love that you frame it that way with compassion, because it really is compassion. And compassion's scary because I think for some leaders and some institutions, compassion makes people feel like progress is going to slow down. Compassion makes people feel like, wait, if I'm compassionate with my patient, that means I'm going to spend more time with them, and that might decrease volumes overall. Compassion might mean I'm wearing a hoodie right now. in the lake house because I'm at work. The benefits of working remotely, I was able to schedule only Zoom meetings this week, but I realized I needed to take a breath in a different place so that I could recharge and come back. So we also have to change cultures where, if someone's on paid time off and there's a big meeting and someone comes off of their paid time off and joins the meeting, instead of us saying, you love the organization so much, we're so proud of you, yeah, we need to start saying, next time, don't come off your paid time off. This is your own time. And we honor you and celebrate you. Like, emergencies happen, but let's trust our teams to take care of the work so you can be away from the work when you're away from the work. And, Marcus, I think another thing about narrative that I'd love to share, it is compassion. It's 100% compassion. And what I also love about narrative medicine, it's also about story crafting. Danielle Spencer recently wrote a book called Metagnosis, and we chatted before. She was a classmate of yours, and she was one of my teachers in the narrative medicine program. And when I read her book, Story Crafting, I thought about the way how we are constantly crafting stories. We're a part of other people's stories. Sometimes we're characters, sometimes we're narrators of those stories. But it made me wonder, what happens, Marcus, when we don't get the complete story? And during this pandemic, so many of our nurses have only seen the endings of stories. And every good story in Western tradition needs a clear beginning, middle, and an end. They don't have to happen in order, but when we have those parts, we can make sense of them. Something I did after the Ebola work, when I was in quarantine for 21 days in a small apartment in New York City, I wrote a children's book about a child named Desmond. And he was the first child that I held with the team I was working with, and we stayed with him while he was actively dying, and dying of Ebola. And I realized I never knew any of his story except for that ending. And to try to make sense of it, I wrote a children's book about kite flying and as a metaphor for resilience. And I kind of imagined maybe what Desmond's life would have been like as I met other children in the same region and saw what they are doing and watched them fly kites and things like that. And I think for my own sort of cognitive support, emotional support, spiritual support, I needed to create a story around the only data points I saw. And the only data points I saw was his death. And so I wonder too, can we use narrative as a way to build compassion and creatively help craft stories? Even if we don't have all the details, that's okay. We're creative people. But in bringing those details together and creating new details with people, could that be another way to build compassion for ourselves to help us keep moving forward?
I have to think it is, right? Hearing the stories of others gives us greater perspective. And when we have that greater perspective and we can relate that to our own existence or the existence of our loved ones around us, that's the connection,
Yeah.
right? That's the connection. Well, Tim, I feel like we could talk all day, but before we go here, I want to be respectful of your time. Can I shoot a couple of quick fire questions past you?
Please, and I'll give quick fire answers. And if I get too long winded, cut me off because I can talk.
No, no, that's totally fine. This is the real fun part. So let's say that question number one. I got three of them for
Okay.
you. Question number one. Let's say you are stranded on the proverbial desert island, but you get to keep one piece of art with you, and whether that art is a piece of visual art, it's a book, it's a Netflix series, it's a Broadway production. What piece of art, or another way to ask this question is, what is a piece of art that really speaks to you?
Arvo Part's Spiegelheim Spiegel. It's a beautiful piano and cello duet. And it's a piece, if you've ever seen the HBO production of Wit, of the play Wit, it's the theme that runs throughout that piece. It's simple. Literally, the piano's like boo, 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 and the cello does these long, drawn out notes. That piece, when I hear it, I feel like all the beautiful and not so beautiful memories in my life come back, and they all make sense when I hear that music. So it's music for me,
Yeah,
totally music.
resonate. Excellent,
Yeah.
excellent. All right, second question for you. Let's say that you open up your wallet and your PayPal account or your crypto wallet, whatever it is, and you found that $100 had magically appeared in your wallet, but you have to spend it on yourself before the end of the day. What do you spend your $100 on?
On myself, before the end of the day. Ooh, I have a neighbor. We live in Atlanta. His name is Ricky. He's unhoused, and I pass him frequently on the street. He picks up odd jobs here and there. I would give it to him, and in return, I would just see if he's got some time to chat. Because sometimes he'll stand by the traffic lights and ask for money and things like that. And he's trying to make money to make rent and things like that. So I might be like, hey, if I give you this 100, can we talk for 5 minutes? Because I want to learn more about you and connect. Rick is a sweet guy. And once I was walking my dog, lost my cell phone while running with my dog in an area where Ricky hangs out. And I remember I spent like an hour trying to find my phone. And Ricky went to help me find the phone, even though he was still standing trying to collect money and food and things like that. He like gave up his time to help me find my cell phone. We never found it, but now when I see him, he still asks me. He's like, "What about that phone, Tim? Where's your phone? Did you find it?"
It's interesting that you say this. We were, my wife and I were just watching some TikToks or YouTube videos last night, and there was a kind of a social experiment that happened. A guy, I believe it was in LA, guy walked up to just random people on the street, and he'd say, "Hey, I lost my wallet. Could I get $2 for bus fare?" And that was it. He just asked that question. And if they said, no, thank you, or, sorry, I can't, he just let them go. But if they gave him $2, he would say, hey, I want to let you know that actually I didn't lose my wallet. And by you being so generous, I want to be generous to you. And he'd pull $1,000 out of his wallet and give it to that individual.
Whoa.
And what was so special is a lot of the people that were giving him $2 didn't really have $2 to give, right? We're talking about people who are unhoused and just living on the streets, barely getting by. And yet it's sometimes those who have the least that are the most generous, right?
Yeah.
Sometimes those, and it sounds like you got a guy right there like that.
Yeah, it's mind blowing.
So,
Wouldn't it be great if the people that were the richest could be as generous as the people that are financially the poorest? Think of how different
yeah,
this
it'd be
world would
nice.
be, you know?
Right, right. We can easily solve the poverty crisis in our world
Yep.
if that were the case.
Yep.
And so my last question for you today is: let's say you have the world's largest billboard on the world's highest mountain. What is the message that you want to give to humanity?
Keep looking up.
Keep looking up.
Keep looking up.
Keep looking up.
I've learned over time there's some neuroscience that actually suggests it's a little bit of research. I don't know how much it's been replicated, but it actually suggests that when we actively look upwards or think about looking upwards, we engage our brains in sort of a different attention span that's more concerned with others around us instead of ourselves. And the research also suggests that when we actively look downwards, we engage more of the egocentric mind. And it scares me. We see all these people, walking across the street in front of traffic, looking down at their phones. Like, yeah, so keep looking up. And I think about kites. When you see a kite flying or experience a kite flying or experience laying on your back and your face is pointed upwards towards the clouds, like that generally feels really good. And sometimes we just need that good feeling. So maybe just it begins with looking up. So keep looking up.
Good stuff. Good stuff. Well, Tim, thank you so much for being with me today. I look forward to meeting you, hopefully in the not too distant future.
I love that.
You seem like a guy who's a brother from another mother. So I look forward to continuing our conversation at another point.
Absolutely. And Marcus, thanks so much for all you do and your time and for bringing these stories forward.
Absolutely. Thank you. And thank you, everyone, for tuning in to this episode of Compassion and Courage Conversations in Healthcare. This is the podcast where I teach compassionate communication, provide perspective, and inspire resilience. A special thank you to everyone who has rated and reviewed and subscribed and shared and thumbs up and liked and put a little ring on the bell. Thank you all so much for helping us get the word about the podcast out. We'll see you next time on Compassion and Courage.